Baylor, and he now serves as an assistant. Oh, sorry, I just got the notification about the recording. And he now serves as an assistant professor in brain injury medicine at Penn State. So I'm super excited tonight. He's going to be talking to us a little bit more about post-traumatic headaches.
Perfect. I'm excited that the team have me, and congrats to everybody that matched. And hopefully this is a helpful presentation moving forward. So a pleasure having you invite me. So as Juliet said, today we're gonna be speaking a little bit more about post-traumatic headaches, introduce certain terms that we use in the evaluation, brain injuries in general, pain, and I think most of the terms will be helpful whenever you all encounter Spanish speakers in the community. So briefly, the content of this presentation will be to describe the pathology, incidents, and the epidemiology of post-traumatic headaches. How do we evaluate them? Summarize and try to introduce a treatment plan that could work for some patients. And then we'll, in the meantime, familiarize with common Spanish terms that we use during the evaluation of these patients, and potentially improve the communication with this patient population, which is one of the goals of this group from PM&R. No conflict of interest to report on my end. I just work for the Penn State Health System, so I'm assistant professor at the College of Medicine in Penn State. As a background, why bring up this topic? Traumatic brain injuries and whiplash injuries which occur on the neck, they may lead to the development of post-traumatic headaches and eventually become one of the most common complaints that we see both in the outpatient and inpatient world. On the right side, we have the brain structures. Imagine if what we learn in medical school is, imagine you're shaking the brain within an enclosed system. It's gonna be possibly hurting certain areas in the brain. So that could be part of the concussion aspect of it. And then the whiplash injury itself, it's basically the neck movement, sudden neck movement that we see, especially when patients are being hit from different angles. So typically we see the neck moving around certain structures that are going to be more susceptible to injury than others. And then, as I mentioned, headaches are going to be a common complaint in general life. About 85% of patients or people in the world complain of headaches at one point in their lives. So imagine if any patient has any injury like this, they'll be at a higher risk of developing this complication as part of their disease. Post-traumatic headaches themselves are described as secondary type of headaches, so are headaches that happen because of something else. And they're basically defined as those headaches that occur within 7 days of having a brain injury or a head injury, or the ones that happen just after patients regain consciousness from a head injury. Studies in concussion population and brain injuries in general, they have shown inverse correlation in between severity of the trauma itself and the incidence of headaches. So for the students that are at just starting medical school and are involved in our groups, traumatic brain injuries are classified from mild to severe injuries. All concussions could be described as mild traumatic brain injuries, but not all mild traumatic brain injuries are considered concussions. So in literature review, you may see that certain authors interchange both terms, but they're completely separate. But basically what literature has shown is that milder brain injuries have the capacity to describe the symptoms, so it's more prevalent in that population when compared to severe brain injuries who may have memory issues or cognitive differences that may impair themselves from explaining the complaint itself. Incidence has been found in certain studies to be as high as 90% after a concussion, especially in the mild traumatic brain population. Typically, it's going to be presenting as a combination of cognitive, emotional, and other symptoms that include dizziness, mood liability, sleep disturbances, neck pain, and photosensitivity. So that's usually the cluster of symptoms that we see after a concussion, and they go along with headaches. So risk factors for patients who to develop post-traumatic headaches are going to include gender. Literature has shown that female patients do report a higher prevalence of post-traumatic headaches. Headache history, so patients who have a history of any type of headaches, either tension headaches, migraines, or others, are going to be at a higher risk of having post-traumatic headaches. Injuries related to sports, especially football, ice hockey, cheerleading, soccer, those are the most common sports that we see concussions happening, and those are going to be the ones most likely reporting headaches after a trauma. Then patients who have had a history of repetitive head trauma, they most likely will be aware of the symptoms and will possibly be paying more attention to those and reporting the headaches more frequently. Patients who have a history of PTSD are most likely to report post-traumatic headaches. Patients who have concomitant vertigo or vertigo prior to the traumatic event, and patients who have a history of insomnia. So we can do our first introduction of different Spanish terms that we could possibly use in this patient population. In general, as I said, traumatic brain injury, it's the general term that we classify concussions in. And basically the Spanish translation will be lesión, will be directly related to injury, traumática, which is traumatic, and then cerebral, which will be brain. It's usually the Spanish words will be Latin roots, so some of them make more sense, and we may possibly use them in another patient population. Concussions, it's a complex word in Spanish, so it's we call it conmoción, which will be the concussion itself, but that doesn't give any specific brain injury itself. So we accompanied conmoción with cerebral, which will be brain. Then during the evaluation itself, we may use certain words that are going to be typical, especially when we are asking patients, could they describe their symptoms, or if we can encompass them within a specific question. So do you have will be a useful thing to know in Spanish, and it directly translates to tienes. Difficulty will be dificultad, which is pretty similar. Dizziness will be mareos, and one way that I see it is imagine if you are in the sea. The sea translates directly to mar or ocean, océano. So mareos have to be with people who are on the sea for a long time. And then we will use, do you have any dizziness? ¿Tienes mareos? Sleep will be dormir, or will be, ¿tienes dificultad al dormir? Do you have any difficulty to sleep? And then history depends on the meaning that we want to do on our sentence. We could use historia or historial. And I would be happy to share this presentation with the team so that you can review if anything. Then whiplash is also a complex word in Spanish. It's called traumatismo cervical, which is traumatic cervical injury, but we use that word as a direct translation. Then headaches will be described as dolor de cabeza. Whenever we're asking a patient about their headaches, we ask them, ¿tienes algún dolor de cabeza o tienes dolor de cabeza? Neck pain will be about the same. And then sports, some of these patients are going to be coming due to a sports-related injury, or whenever we're rotating with in our rotations, we may see athletes, and then we could be able to ask them, what sport do you practice? ¿Practicas algún deporte? ¿Qué deporte practicas? So those will be the initial Spanish terms that we could use. So for evaluating post-traumatic headaches, there are going to be certain challenges that, to be honest, even now, I'm almost 9 months out from training. I still find myself having difficulty trying to figure this out. And the reason behind this is there's really not a standardized exam to evaluate for post-traumatic headaches. Each provider will have their own system to go through. There are things to add to the physical exam. And as a result, we see a high variability in the examiner's history taking an exam. But what we know for sure is that we do need to involve a complete exam, do a complete assessment into the headache evaluation, and we cannot evaluate them all and try to fit them all in the same box. So I just wanted to bring these images because they show how complex the brain and neck connection is. So we have veins, we have arteries, we have structures that enclose the brain itself, like the dura, the pia, and the arachnoid matter. We have muscles, we have different joints. We're gonna have nerves related. So imagine if we have a concussion or we have any type of head trauma, and we also have a whiplash injury. Most likely all of them will be involved, and all of them could be potential pain generators. So it's important not to focus ourselves too much on the exam and the history, and try to take a broad approach towards evaluating this patient population. So this diagram provides the different mechanisms that are proposed for the post-traumatic headache development in the brain injury population. So there are different things that happen. We have systems in our brain basically saying you're not in any pain, and they modulate pain receptors in our spine, especially a connection between the cervical spine, C2, C3, and also the trigeminal nerve. So a connection between the trigeminal nerve and the cervical spine is the one basically letting us know there's no pain, no need to feel pain. Whenever we had a head trauma, this modulation system becomes impaired. There's also a release of excitatory neurotransmitters like glutamate, calcium, and basically what those do is kill the neurofilaments, neurotubules, and cause ion exchange within the neurons themselves. Then there's a mechanism called cortical spreading depression, which basically irritates more the trigeminal nerve and the cervicogenic aspect of the spine. Then there's also a calcitonin gene-related peptide-dependent mechanism that releases certain neurotransmitters that make the membranes to be more susceptible for pain, especially on the brainstem. And then there are other pro-inflammatory mediators that basically vasodilate the brain structures and accumulate basically pro-inflammatory mediators and cause more pain. So it's basically a vicious cycle, just having everything being thrown out of place, eliminating the modulating system. So it's always gonna cause that vicious cycle of just having headaches. Common pain generators and descriptions that patients use for post-traumatic headaches include headaches that may feel like migraines, so headaches that go accompanied with photophobia, phonophobia, behind the eyes. They may get worse with interacting with others, or we also could get headaches that are more tension-related headaches, so the headaches that are more like a band going around the head. Neuralgic type of pain, which will be more in a distribution of nerves. Usually what we see is greater or lesser occipital nerve neuralgias, but depending on the mechanism of injury, we may get to see supraorbital nerve injuries. Craniomandibular related pain, so that will be more with the temporomandibular junction. Cervicogenic nature of the pain, which will be more suboccipital pain or pain in the base of the skull, pain on the neck. It may even radiate towards the arms. We may get to see myofascial pain, which will be more pain related to the muscle themselves, muscle spasms, rotation of the cervical spine, other musculoskeletal generators, and as a result, physicians feel the need to treat them. Patients sometimes take the matters on their hands and decide to take NSAIDs or opioids that they may have for other things. And eventually this may also lead to medication overuse headaches. So it's finding the perfect balance to prevent medication-induced or medication overuse headaches, as well as trying to figure out what works for the patient. There are certain potential confounders for the post-traumatic headaches. There are patients that may use different substances. Cocaine has been one of the most commonly associated with certain headaches. Caffeine itself may be a potential cause for headaches, and we basically live on caffeine. Sinusitis. There are patients who have seasonal allergies that may predispose them to getting post-traumatic headaches. There are patients who may have a trauma, did not have any symptoms of headaches, and when they go to the ED, they get an imaging done, they may find an intracranial mass. And there are always patients who may look for secondary gains in regards to, do I just get out of work because of this pain, or I could potentially get a settlement deal with a company as a result of this pain. So that's where we could play a big role into this. So starting with the history taking, and then I'm gonna also provide certain terms that we can use during this period. The history taking will be as any other patient, but we will just add these things on top. So it will be very important to ask for any headache history. And if there is, how did they treat them in the past? How would they describe that headache history? If there's any family history of migraines, so we could potentially be seeing the development of underlying migraines in this patient. Has he had any prior treatment before coming to our evaluation, and has he responding at all? Have they been responding at all to this treatment? The temporal relationship between the headache and the injury itself. As I said, the post-traumatic headache period will be the first 7 days after the injury, but patients could potentially develop headaches later in their recovery process. What's the evolution of symptoms? Have there been any nausea, any vomiting, any rhinorrhea, any eye pain? So just see how the patient has been changing through time. What's the severity of the pain? Does this pain really limits the patient in different areas, or does it not? What's the frequency of the headaches? Are they happening all the time? Are they happening all day? Do they ever go away? Do they happen after a specific trigger? And that's where we get into the triggers. Is the trigger an exposure to certain things? Is the trigger more a substance that they're using, like medications or caffeine or any specific foods? And then any other associated symptoms like loss of consciousness, dizziness, vertigo, depression, or multi-liability. So those will be very important to add into the history taking of this patient population. So then we could get into some more of the common Spanish terms that we could use potentially in the history taking. I know that the group has students at different levels in terms of their Spanish knowledge. So I wanted to bring simple Spanish as well as some things that may be more complex. So cabeza basically translates to head. So head pain, headaches, dolor de cabeza. Ojos will be directly translating to eyes. Oídos will be ears. Nose will be nariz. Pain itself will be dolor. And then sentir o sientes will be feel. One of the things that could be really useful is, even though I may use terms in Spanish, people with different backgrounds or coming from different countries may have regionalisms, but most of us, we use a lot of hand gestures. So I would say in future encounters, if the patient is having significant issues, recognizing what you're trying to ask, you could just point into a certain area, and it could be really helpful for the patient to confirm, oh, okay, the physician is asking me for pain here or there. So it's something that it's really useful. And then if we want to ask the patient, are you having headaches? Then we ask, ¿tienes dolor en la cabeza? Or if you feel it around the eyes, which will be a typical migraine type of headache, lo sientes detrás de los ojos, behind the eyes. And that will be a good way to make a simple approach towards these patients. Then transitioning from the history taking to the physical exam, things that we could potentially look for will be starting with the inspection, looking for any asymmetry, any specific injury, any atrophy, so that we're possibly not missing something else going on. Any differences in their posture. Some people have kyphosis, or they may be anteriorly flexed on their necks, or they may develop a dystonia, which will be more a torticollis type of movement or anterocollis. So it will be more a tension type thing on their muscles. We will evaluate the range of motion of everything, including the head, the neck, shoulders, and potentially ask the patients to open their mouth so that they can show us how the range of motion of the jaw is. Then we will proceed with palpation, palpating the temporomandibular joint, the neck itself, the face, looking for any triggers for pain, any tender points, any sensory changes. One of the things that I've noticed is that a lot of patients have tender spots around the trapezius area, around the cervical paraspinal muscles, around the periscapular area. So in between the shoulder blades could be potentially tender points that could trigger headaches. And then I'm just gonna go a little bit deeper into how we could try to differentiate the potential underlying cause for their headaches. So musculoskeletal related headaches or myofascial pain headaches, they could be typically described as a dual type of pain or achy pain. It may be very localized, but it also may be to spread it around. Usually it is a constant thing, so they may let you know that it doesn't really improve with anything besides rest. And they may get worse with range of motion or certain activities, especially overhead activities will be things that could trigger their headaches. Usually it improves with time. So whenever I have a suspicion that this is one of the major causes, I tell the patients just try to sleep properly, try to get a soothing sleep, and then it will get better with time. Of note, depending on where the generator is, if it's in the neck, like the sternocleidomastoid, or on the scalings, it could potentially lead to tinnitus or even dizziness. So it is important to tell the patients about that. And here I have a diagram of how we think tender and trigger points are and how they could potentially generate pain around different areas. So if we can think of most of these muscles are being involved in a concussion and or a whiplash injury. So most likely they could potentially cause a pain through all the head, which is a common complaint that patients do get. Then we could get more into a cervicogenic type of headaches, which earlier I said there's a connection between the trigeminal nerve and the C1, C2, C3 roots. Basically, they do combine and cause pain, and that type of pain will be more described as a base of the skull pain. It could be unilateral or bilateral pain, and it could be potentially getting worse with certain provocative maneuvers. So at that point, I do test for facet load or Sperling test, just trying to look for these type of triggers for their pain. One of the common things that we do see is that the facet joints of C2 and C3, they may be triggers for these types of headaches. So some of these patients, if they don't get better with rest, if they don't get better with medications, we may consider an MRI of their neck so that we evaluate further the facet joints or the sigmoidophyseal joints. Then we have medication-related headaches. I wanted to bring it up because sometimes we don't think about certain medications that could cause headaches. And these are considered the easiest ones to treat and could potentially lead to a significantly improved quality of life. The most common medications associated to medication-related headaches include phosphodiesterase inhibitors like Viagra, cannabis, calcium channel blockers like Norvas or amlodipine, non-steroidal anti-inflammatories. So most of the patients rely on these things before coming into evaluation. And sometimes we just need to tell them to back off of them and see if we can treat them with an alternate way. Histamine blockers, amiodarone, and then withdrawal of caffeine, opiates, or ergotamines, which we will be talking a little bit about them later. So, as I briefly said earlier, this history on physical exam is not really, there's not really a standard to have. The same is with the treatment, unfortunately. But at the same time, it is good that it's not a standard because, as I said, not every patient will have the same complaints and not everyone will have the same response to different therapies. So treatment should be targeted towards the headache endotype, the response history, as well as any history of prior headaches. It is very useful to track symptoms, but at the same time, it could be mentally taxing and even a trigger for headaches if the patients are just over-focused about their headaches. So what I just educate them on is if I'm gonna start anything, I just tell them, see if they're less common, if they happen less throughout the day or throughout the week, how often do they happen on the week? And that usually help us out to see and measure response to treatment. There are not that many studies around that support one treatment versus the other, and most of them are gonna be retrospective studies. So basically what we've done is just extrapolate treatment from other types of headache treatment. Thankfully, there are both pharmacological and non-pharmacological treatment options, which there are patients who are going to come to your office and just clearly say upfront that they don't want any medication. So there are things that we can do without any medication. So just starting with non-pharmacological treatment, all of the time that I have any patients with symptoms like this, I discuss with them about lifestyle modification, trying to achieve a soothing sleep, reaching the REM stages that has been shown to be helpful for headaches. So I always tell them about that. The importance of nutrition, hydration, it's also really helpful in terms of their symptoms. So I educate them about that. We could also potentially use therapeutic heat and cold. Usually heat promotes relaxation of muscles. So if there's any potential tenderness on their neck or tenderness on their shoulders, heat could potentially be something that's really gonna be helpful for them. Cold may just slow nerve transmission in the small fibers. Of note, the small fibers are gonna be major role players in pain generation. So there may be certain things that they look like a band and they go around their heads. And there are patients who could do just really good with that, especially if they have like a tension type of headache thing. Then some patients do benefit from referring to physical therapy, and in physical therapy, they may undergo mobilization, manipulation of their necks and head, shoulders, doing a specific techniques like myofascial release. These may be helpful in this patient population, but there's not enough data to just say, oh yeah, it's clearly helpful in these patients. Then there are patients who are going to be just lingering with their symptoms. They may not show significant improvement, and they may benefit from just doing a referral to a psychotherapist or a psychologist to work on cognitive behavioral exercises. So learning about breathing exercises, getting to know your body, mindfulness, biofeedback, and other relaxation techniques could potentially be really helpful, especially if coupled with different pharmacological options. Then now entering the last part of the presentation, we're gonna be talking a little bit more about the pharmacological treatment that could be available for these patients. And we separate them in between preventative and abortive therapies. They share a lot with just migraine or tension type headaches. As abortive therapies, we have non-steroidal anti-inflammatories, which has been found to be one of the best alternatives for patients who have non-disabling migraines. We have ergot derivatives like sumatriptan is one of the most common. They may be considered, but shouldn't be a long-term thing because they may have potentially a side effect of having medication overuse headaches. And then Gepants, they're basically newer medications that work on the calcitonin gene-related peptides, and they may be really helpful for patients who get bouts of headaches or get headaches that are similar to cluster headaches. So those will be abortive types of therapies. Then for cervicogenic type headaches, sometimes we couple just pain medications with muscle relaxants, and they could be considered as an adjunct therapy and could be really helpful in achieving complete resolution of the pain itself. Then as prophylactic therapies, we basically extrapolate them from other pain syndromes. We could start from tricyclic antidepressants like Elavil and Pamelor, which are gonna be possibly considered as first type options for tension type headaches. Other medications like Cymbalta or duloxetine could be considered. Beta blockers like propranolol, verapamil could be considered as well. Anticonvulsants have been shown to be helpful, especially gabapentin, which has a significantly safe safety profile, could be potentially used in this patient population. Other anticonvulsants, more especially Topamax or topiramate, could be really helpful, especially the mechanism that is suggested is that it decreases the neuronal firing from that connection between the trigeminal nerve and the cervical complex. However, the side effect profile is a little bit more complex, and patients usually don't like the side effect profile. So it's it depends a lot on the frequency of the symptoms, the response to other medications, and that the Topamax could potentially be considered. One thing that we also use in brain injury in general is that patients may have different things going on, and we want to use a single medication to treat different symptoms. So patients who may have behavioral changes, like agitation, we may consider medications like Topamax. Patients who have sleep disorder, pain, and headaches, they could potentially benefit more from the Elavil because of the spectrum of things that we could cover with the same medication. Then one of the things that I really like to add into our into any conference will be areas that we could consider to expand our research and try to figure out if there's any room for improvement in the treatment for this. And right now, we don't know for sure if patients who are treated early, when compared to the ones that are treated later, meaning weeks later, if that impacts the headache progression. We don't know for sure how the natural history of untreated post-traumatic headaches go. A lot of patients that have concussions, whiplash, brain injuries, they don't make it to the ED, and they just stay at home because of lack of insurance, not feeling safe enough. We don't know if they do develop them and if they eventually go away by themselves. How does it really impact return to work? Is it a real barrier for patients to return to work? We don't know for sure if there are any cultural or age-related variables. And we also don't know, and I think this last one we will never know, how does coping mechanism impact the post-traumatic headaches course? So these are my references, and then I finish the session with a room for questions and also sharing my favorite picture from Puerto Rico, my island. Oh, I finish on my end. Any questions from anyone?
Thank you so much, Dr. Lopez. This was a really great presentation and really informative, and I really like how you included all of the phrases that I think were really useful for all of us at any level of Spanish, just to remember. Does anyone have any questions for Dr. Lopez?
I guess one thing that I wanted to ask I know that your specialty is more in terms of brain injuries, but just in the idea of like headaches. I have seen a couple patients before who developed headaches after COVID, and I was wondering if you've seen that and have any types of medications or treatments that work for that type of headache.
So to be honest, I think I may have encountered certain patients that are both long COVID and a concussion after the long COVID. And I think basically the approach has been the same, but in our system, we don't have a long COVID clinic itself, so I haven't had the experience. At least I can recall one patient that she has long COVID, and she had a concussion after a fall at her house, working on her garden. And the way I approach it is I did simple things. She had supraorbital neuralgia. And for that, I just recommended her to try and use a lidocaine cream. So as simple as that. But she also has some component of cervicogenic headaches. So I eventually sent her more for PT because she didn't want to try any medications. And on top of that, she has chronic kidney disease. She has hypotension. She has orthostatism. So we did discuss different alternatives to try, but the patient felt more comfortable just trying out the lidocaine cream and the PT for her symptoms, and it has worked beautifully. So that's a great question. How will that population respond, or do they just respond similar, and do we just take a similar approach to that? I think the mechanism for headaches after COVID hasn't been really described, like for headaches themselves, but it could be similar to migraines. So I think an approach like migraines could be helpful in terms of how disabling they are, how frequent they are. And if there are no comorbidities, trying NSAIDs could be fine. So I think an important aspect is we have so many options, but each patient is different. They come with different backgrounds, different cultural backgrounds. So some are gonna accept medications easier. Some you're gonna have an extensive discussion and they're gonna take a long time to just try something, because to some patients this is really disabling. I had, just to bring one experience that has been helpful for me and really educational, is I had a patient who came to me referred after a wall on her job site fell on her head. She had been seen by different providers to go back to work. She was sent a couple months afterwards to me. She still has significant headaches. She had neck imaging, she had brain imaging, so she had everything done. We decided to repeat our neck imaging. It did show progression from the one that she got earlier, her injury moment. And now we're possibly going to approach her with a surgical approach. So I think there's room to improve a lot. There's going to be barriers from insurance, from the different systems. But potentially there is room to at least improve their quality of life, which is one thing that I discussed with this particular patient. They felt like they were never gonna get better. And I said from the get-go, you're gonna get better. I'm not sure what's the timeline for you, but you are. And so far she's gotten better. So it's just trying to provide that educational aspect and trying to work it out with them. And great question, though.
Thank you. Yeah, that was all very helpful. Does anyone else have any other questions?
Okay, if not, then thank you so much, Dr. Lopez-Aponte. We are going to upload this recording to YouTube so that all of our other members can watch it on their other time. So thank you so much.
Thanks for having me. Good luck to everyone. And congrats again on everyone who matched. And in the upcoming years, feel free to consider Penn State as a residency spot. So good luck.
Thank you. Thank you so much for joining us.